Welcome, everyone. It's a pleasure to be here, to be invited in discussing our paper, our last effort. I'm Andrea Necchi. I'm professor of oncology at Vita-Salute San Raffaele University in Milan, Italy, director of VJOoncology in San Raffaele Hospital in Milan, Italy. Framing the context of the work that we have done with the aim of setting the scene for the next generation clinical trials, so aim at sparing the bladder in patients with the muscle-invasive disease. First of all, the need was basically due to the fact that there's an increasing number of patients with muscle-invasive disease, so T2, T4, N0, M0, muscle-invasive urothelial bladder cancer, that receive neoadjuvant therapy of any kind within trials or standard of care therapy. And at a certain point in time, in particular based on the evidence of response to treatment, deep response to treatment, refuse cystectomy and ask us to provide an escape strategy, an alternative way of curing them by saving the bladder. So a response-adapted approach. In JCO, we have recently published the RETAIN study that was the first of its kind trial that was aimed to provide a response-adapted approach in this patient population. And a similar study was pursued by Madgalski and colleagues in the United States by using standard chemotherapy plus an immunotherapy drug, nivolumab, with the same design. So starting with systemic therapy and then shaping the way of treating the bladder with alternative treatments rather than radical cystectomy, depending on the response to treatment. So, based on this and based on the pressing need by the patients and multiple parties, we have convened at Milan in December in conjunction with our annual GU-oncology retreat that we routinely do each year in San Raffaele, by convening a multi-stakeholder table involving a lot of key opinion leaders from multiple specialties, radiation oncologists, medical oncologists, urologists, pathologists, and so patient advocate representative from both sides of the Atlantic, so from the BCAN, from the World Bladder Cancer Patient Coalition in Europe, and also involving patients from pharma company providing their insights, and patients from the regulatory parties from the US FDA and from EMA. To me, personally, it was the first time that I saw both these parties sitting on the same table discussing a unique topic. So, what resulted actually from the discussion and from the consensus meeting was a clear definition of clinical complete response, to use clinical complete response after neoadjuvant therapy, neoadjuvant experimental therapy, or neoadjuvant therapy as standard of care therapy. That is in particular based on the accomplishment of each of three of these points. So negative cross-sectional imaging, CT scan or MRI scan after treatment, a negative biopsy, or even better, a VT or RBT for the pathological assessment of response into the bladder, and negative urine cytology. So clinical response should not be based solely on imaging, but it should also be confirmed by two different methods. First, and then for the rest and for the remaining discussion, we focus on the use of clinical CR or other endpoints for registration trials or for proof of concept studies. And we all convene that clinical complete response is still a bit immature to use in registration studies, because there is still uncertainty with regards to the surrogacy towards survival endpoints. So we are still at the beginning of the journey. So it's a very, very good biomarker interim endpoint to select patients to screen the most active therapeutic drugs to provide in a neoadjuvant setting. But when looking at the registration studies, event-free survival, so a survival endpoint, in particular event-free survival, emerges as the most robust endpoint to use, with the only exception of overall survival for sure, to use as a potential primary endpoint for registration studies. It's important to underscore the fact that the definition of event-free survival is a bit different from the bladder intact EFS that is used in bladder-sparing chemoradiation studies, because in this case, we convened to include all the type of tumor relapses post neoadjuvant therapy, including the superficial high-grade disease relapses into the bladder. That is the most frequent scenario that we see in this kind of approach. So patient having a recurrence of PTA high-grade or PT1 high-grade into the bladder without developing this metastasis. And these events should be counted as events in the EFS definition, so that we can accomplish all the kind of situation that may expose the patient to the risk, not just to have a disease progression, but also to lose the bladder because of the fact that they develop a high-grade disease into the bladder, so losing the endpoint of being cured by saving the bladder. Uh, at the end, I think that is this consensus paper provides a good framework for the next generation studies that are expanding in this area. There is one missing piece in this puzzle that is represented by the use of liquid biomarkers. ctDNA or utDNA in the future are emerging as strong prognostic markers, biomarkers in this disease. At the point, at that time, at the time of the meeting in December, there was still uncertainty regarding the incorporation of ctDNA data into the formal definition of clinical CR and the formal use in next generation studies. But it's more than likely that in a 1-year projection, we will be in the position of updating this definition by incorporating newer biomarkers to use for the patient benefit and for optimization of the design of these trials.